everyone, my name is Ember and I'd like to introduce myself and my group members and acknowledge our roles in our debate about teletherapy. Sydney Allen will be representing the pro-teletherapy side as our pro-stater, and I will be representing our con-teletherapy side as the con-stater. Bria Long will be our prover and attacker for the pro-teletherapy side, and Gracy O'Reilly will be our prover and attacker for the con-teletherapy side. Sydney Allen will follow up by salvaging any intact variables for the pro-teletherapy side, and I will be salvaging any intact variables for the con-teletherapy side. Our conclusion will be summarized by Bria Long. Our debate topic is teletherapy, specifically the pros and cons of ABA practitioners providing virtual appointments for teletherapy sessions, as well as parent training sessions. We will be presenting our debate formally. Applied behavioral analysis is a behavior science-based practice that utilizes evidence-based interventions to teach individuals effective or alternative behaviors through antecedent strategies and consequence strategies through one-on-one direct therapy services, and that is pulled from the BACB website's fact sheet. Treatment has traditionally occurred in person. However, with advancements in technology and flexibility that virtual meetings provide, the application of ABA through teletherapy as well as parent training sessions are being explored as alternatives to traditional in-person practices. The purpose of this debate is to highlight the strengths and weaknesses of telehealth as a modality in treatment for ABA. We also consider the ethical considerations of use of teletherapy in parent training while addressing its efficacy. We will focus on parent treatment fidelity, parent satisfaction, problem behavior reduction, skill acquisition, and cost effectiveness, and convenience of interventions during our debate.
We would like to begin by asking a few research questions for your consideration when viewing this debate. Now, these questions are limited and do not cover all aspects that are talked about within this debate. However, we believe it is important as future clinicians to provide these questions to ensure a comprehensive thought pattern when dissecting this research. These questions include: does telehealth allow for the same level of skill acquisition as in-person therapy for children with autism spectrum disorder? Does telehealth allow for decrease in maladaptive behaviors for children with autism spectrum disorder? And lastly, is telehealth more or less costly for clients, stakeholders, and clinicians in ABA service delivery? Hello everyone, and thank you for tuning in to this exciting debate ahead. My name is Sydney Allen, and I'm going to be representing the pro side of the debate as the pro-stater for teletherapy. The pro side would like to begin by briefly describing some background information on teletherapy in the ABA community. It will be mentioned that the majority of research on implementations of ABA have been conducted in in-person contexts. However, with growing technological advancements and the increase of research on its efficacy, telehealth has grown in its practical use for families and individuals who are seeking treatment, specifically for children with ASD or autism spectrum disorder and parent intervention applications. Additionally, the COVID-19 pandemic inspired a need for alternative modalities to continue provision of services to clients and families while complying with social distancing guidelines. There are several investigated benefits of the utilization of telehealth-based services, such as treatment generalization, increased affordability, continuity of services, and much more, which will be discussed within this debate. The pro side's first key points include the capability of telehealth in managing staff shortages, providing a more cost-effective option for clients and families, and the potential for high-quality therapy. For each point, we would like to address an ethics code which best supports the implementation of telehealth. Let's begin by addressing Code 2.19, addressing conditions interfering with service delivery. Many geographical areas struggle with staffing shortages, which can hinder service delivery. Being put on a wait list can be very discouraging for clients and their families. Teletherapy allows for analysts and therapists to connect with these families virtually and provide access to treatments and interventions they otherwise would not receive. Code 3.01, Responsibility to Clients. As behavior analysts, we are expected to act in the best interest of clients, take appropriate steps to support clients' rights, maximize benefits, and do no harm. Implementing treatments which result in reduction of cost for clients can help support them in delivery of services. In many cases, telehealth services can be offered at a lower cost to in-person therapy. Telehealth can also reduce travel costs for families as well as clinicians. This level of cost effectiveness can allow for increased services for clients and families in need. Lindgren and colleagues in 2016 compared costs of 3 service models: in-home in-person therapy, clinic telehealth, and in-home telehealth. They calculated staff costs, facility costs, and family costs for each treatment. The results demonstrated that both clinic and home telehealth options were less costly than in-person in-home therapy. However, in-home telehealth was the most cost-effective option, with a $3,804.33 cost reduction compared to in-person home therapy. Code 2.13, Selecting, Designing, and Implementing Assessments, and Code 2.14, Selecting, Designing, and Implementing Behavior Change Interventions. BCBAs are expected to best meet the diverse needs, contexts, and resources of the client and stakeholders when selecting, designing, and implementing assessments with a focus on maximizing benefits and minimizing risk of harm to the client and stakeholders. In many research studies, telehealth has been found to be successful for behavior analysts when conducting functional assessments, collaborating on creating behavior plans, classroom management techniques, and training educators, parents, and caregivers on various intervention strategies. Rooks Ellis and colleagues in 2020 identified several interventions which have been found to be successfully delivered using telehealth, including functional communication training, pivotal response training, and behavioral consultation. Additionally, the previously mentioned study by Lindgren and colleagues in 2016 included 3 groups which had a total of 107 participants who were all children between 21 and 84 months, all diagnosed with autism spectrum disorder. And their results found over a 90% reduction in problem behaviors with the use of functional communication training in a telehealth format. So here we have addressed a variety of research suggesting that telehealth is indeed effective in managing staff shortages, decreasing costs to clinicians, families, and facilities, and can provide access to high-quality services for families in need. So here we have included a graph figure from Lindgren and colleagues in 2016, which demonstrates the average weekly functional analysis and functional communication training treatment costs per child. Now, you can see here we have in-home therapy, clinic telehealth, and home telehealth. And you can see that as we go through the treatment modalities, the cost reduces significantly, and home telehealth is the most affordable option within this study. I also want to point out the average total costs per child, and they did 3 to 5 sessions per child, which were 60 minutes per session. And as you can see, we have in-home being the most costly, clinic telehealth being less costly, and then in-home telehealth being the most affordable option for the families and the facility and the clinicians.
ABA therapy has traditionally been conducted in person, one-on-one, which means that ABA has only been studied in that context. So limited research on virtual ABA implementation has been conducted so far. And it is important for practitioners to consider the ethical issues of implementing ABA therapy virtually, because one might argue that those applications are not evidence-based because there is limited research on implementing those procedures virtually. Some ethical codes to consider are codes 2.01, which is providing effective treatment. It is the BCBA's ethical duty to prioritize the client's rights and needs in service delivery. And that can be applicable to situations of virtual ABA therapy. The BCBA must look at the client's needs and the overall effectiveness of the treatment, right? Like, can we, as a BCBA, determine if the client is responding well to verbal prompting, as some physical prompting might be limited, as well as, is this virtual approach of providing materials and programming online an effective tool for that client? Next, we can look at code 2.09 involving clients and stakeholders. Previously, we had discussed the parents' stress levels, and it's another topic I'm going to talk about here shortly, but involving clients and stakeholders may potentially add more stress to the client, and BCBAs must consider that when making the ethical choice of providing in-person or virtual therapy sessions. Code 2.17, collecting and using data, is another code that may support the virtual ABA therapy sessions are ineffective, because when we look at the application of virtual therapy sessions, we have to consider the fact that the camera is doing a lot of the observational work, whereas in person we can turn our heads, follow, RBTs or BCBAs might be put into the place of not being able to observe or document behaviors and scale acquisition correctly. If a client is in a behavior with a caregiver or parent who is implementing the ABA therapy prompting, that person may not be able to turn and consider the camera angles. They may not be able to properly collect data in those moments because they are untrained individuals implementing ABA therapy practices for us. Another code to consider is 2.19, addressing conditions that interfere with the service delivery. So again, it is the BCBA's responsibility to look at those conditions, right? We have to analyze the environment and say, is this an effective way of implementing ABA therapy, or is virtual ABA therapy unsupported and unsupporting of this individual? Is this able to help us lower maladaptive behaviors and increase skill acquisition or not? Code 3.01 refers to the responsibility to clients that BCBAs have. Behavioral analysts act in the best interest of the client. So another one that supports the claim that virtual ABA therapy might not be appropriate for all clients. We must consider taking appropriate steps to support the client's rights and maximize benefits and do no harm. If we are leaving our clients with individuals who are untrained, individuals who do not understand the components of data collection, as well as prompt hierarchy, etc., we might unintentionally be leaving our client vulnerable to ineffective protocols. And when we look at code 3.04, service agreement, we do have the responsibility as behavioral analysts in upholding our end to our stakeholders. So if we have created a contract between our clients and insurers that states that we will be receiving the client in a clinical setting or providing ABA therapy in the home, we do need to look at those service agreements and make sure that we are reflecting our terms of agreements appropriately. Some insurers may not cover virtual ABA therapy, and that is something for BCBAs to consider when ethically deciding whether or not they're going to provide virtual therapy sessions. Something else to consider when we discuss the cons of virtual teletherapy is the fact that parents self-report no change in stress after attending virtual parent training sessions when compared to in-person training sessions. And this references O'Toole 2022. Oftentimes, parents report high levels of stress, and it is the ethical duty of the BCBA to be supportive of the parents, helping to work to reduce their stress, connect with them, and offer them resources and tools that they need during those sessions. And if parents are reporting no change in stress after attending virtual training sessions, then we must consider, returning to in-person meetings. Conducting ABA therapy also has virtual limitations, which we kind of discussed in the ethics perspective, but also just physical limitations include prompting. A practitioner who is trying to provide ABA therapy virtually has to lean on using verbal prompting or stimulus prompting on the screen of the client. Those limitations do exist because we know that verbal prompting only might not be effective for all clients. We often rely heavily on physical prompting or gestural prompting, which may not be possible in virtual therapy sessions, or may rely heavily again on the caregiver to provide those prompts. Which leads me to my next point. Relying on caregivers to conduct implementation procedures, again, is an ethical concern and also just a practicality concern for ABA therapy, because it relies on someone who is untrained in ABA therapy to provide evidence-based practices. And overall, this might affect the quality of effective implementation, thus resulting in ineffective treatment implementation or acquisition of skills. We might see behaviors spontaneously recover, and overall we might not see the client progress as we expect to. Some other limitations that exist for virtual ABA therapy and virtual ABA therapy parent training include limitations to access of reliable technology. This not only falls onto the practitioner's shoulders, but also the client's shoulders or their families. Families might be required to provide technology or own technology that they might not be able to afford or otherwise might not own. It provides limitations for the provider in respect to consistently providing materials virtually that are not only attention grabbing for the client, but also in respect to parent trainings. Our source, Orlando Yurts 2023, points out that parents only find virtual parent training sessions effective when the materials are clean, organized well, frequently changing, attention grabbing, and so on. Some other limitations that exist for virtual ABA.
So now we're going to talk more about some more things with telehealth and ABA and why they benefit the community and those who need services. We've touched on it a little bit, but the telehealth services have been successful in implementing a variety of different interventions and training, including functional communication training, parent or caregiver coaching, as well as coaching or training for other professionals or practitioners in the field. So teaching them things that they might not be fluent in already. Also functional analysis, naturalistic teaching, and there's others that have been shown to be successful. Sydney has touched on a couple of the key points to show the success of telehealth services. Direct telehealth services often include parent or caregiver involvement. These can be referred to as caregiver-assisted telehealth or caregiver-implemented telehealth. It can be called some other things, but those are mostly what they're called. Caregiver-assisted is where the caregiver or parent acts as a support person, and the therapist actually is still implementing, but there's support involved. And then caregiver implemented telehealth is where the caregiver is trained to implement the actual intervention via telehealth. Both of these methods provide greater parental and caregiver involvement than direct in-person services. This allows for an increased rapport and just a relationship between the practitioner and parent. They have time before and during and after services to kind of ask questions or give feedback, say frustrations that they may be having, or just in general, when a parent is involved through the entire session, obviously there's going to be more of the back and forth, and just also creating a better dynamic and relationship between them. And this can increase the effectiveness and quality of services, which is an important part of ABA. The average commute time in the U.S. is almost 30 minutes. So for therapists providing in-home services, this can also be even more than that. They're traveling back and forth to different houses of their clients. So by providing telehealth, this reduces commute times greatly. There's less demand placed on the practitioner, which allows for better quality services, and they can also increase the quantity of services by having more clients. As also addressed by Sydney, there's a blatant discrepancy in cost services for in-person and telehealth. Similar outcomes have been shown with telehealth services compared to in-person, so cost-effective treatment can allow for less barriers for families. With those with disabilities, this provides for even more opportunity for those in remote locations to receive treatment that might not be able to afford to travel far and wide in order to receive the services that they need. So as long as they have internet access, geographical barriers are lessened. And as with in-person and in-home treatment, telehealth allows for a client to be in a comfortable and known environment. So where their daily routine and where they are comfortable, it can be observed, it can be considered, and then the intervention can also be implemented to allow for a better intervention.
Moving on to some more cons related to teletherapy, it's important to note that there is limited evidence proving its effectiveness. In 2022, Ferguson and colleagues mentioned that child outcomes are varied. Only 54% of studies reported favorable outcomes for all participants. 45% of single-subject research focusing on communication interventions demonstrated non-effects for child outcomes. Whether this limitation in outcomes is a result of heterogeneity common to a naturalistic teaching model or due to specific difficulties in translating effective naturalistic teaching practices to a telehealth platform are important questions to ask. The article mentions that research on its efficacy is somewhat limited as well. While the majority of us work within the United States, I thought it was important to note that as of late March of 2022, there have been no studies published by researchers outside of the United States investigating solely a telehealth platform to provide training to parents in naturalistic interventions, also mentioned by Ferguson and colleagues in 2022. While I was researching, many journal articles reported that telehealth was beneficial to individuals diagnosed with autism spectrum disorder. I found that the description of many of these participants described a higher skill repertoire. So what about those clients with a lower skill repertoire who need additional prompting throughout most tasks? For these clients, a caregiver would be needed on the other end to help assist them through a session as well. So while teletherapy can be argued to be more flexible for scheduling purposes, it must be noted that for some clients, a caregiver's schedule needs to be worked around as well. This decreases flexibility within the idea of teletherapy, as some caregivers would no longer be just dropping their child off and become available during that session time to complete other errands. Instead, they might need to be present with them throughout session. Maladaptive behaviors are often present for individuals with special needs as well. Such problem behaviors could be difficult to intervene on, though necessary, as they could cause harm to oneself or others. For example, if a client were to engage in a severe magnitude of self-injurious behavior in which a reactive treatment strategy is necessary for safety, it might be difficult to do this via teletherapy, even if there is a caregiver on the other end assisting the client. Aggression can also range in magnitude, in which many times more than one practitioner is needed if that magnitude is high enough to efficiently protect themselves and others. Demands placed can often evoke maladaptive behaviors as clients continue to learn, as it's natural to become frustrated at some points. It is also important to note that while a caregiver may be assisting their child on the other end of the screen, they most likely did not undergo the 40-hour behavior technician training. While it's the job of the BCBA to help train and guide caregivers in managing problem behaviors and enhancing the client's skill repertoire, difficult situations often yield an in-the-moment response that may not align with the protocols that were gone over. Teletherapy also leads to a deficiency in the sense of community. For families who have a member or members diagnosed with autism spectrum disorder, it's crucial to build relationships with others who can relate and help support them. Going to an in-person setting helps caregivers to build those bonds with other families. It also enhances social opportunities for the clients as they learn with and from their peers. Moving on to the last point, teletherapy may not even be an option for some families if their insurance doesn't cover it. As stated by Therapy Brands in 2022, teletherapy is covered by Medicaid in 48 states. While this does account for the majority of states, it's important to know that Medicaid was specifically mentioned, in which not all families might have that insurance. Only 32 out of 50 states have some kind of private payer policy in order, also mentioned by Therapy Brands. The source also states that covered services are defined by state law, and even when a private plan covers telehealth, coverage may be limited. There are also variations in reimbursement. Only 23 states with stricter telehealth parity laws have to cover telehealth services at rates equivalent to in-person visits, so that is less than half of the states. So it might be more of an out-of-pocket expense for families. So before one should consider teletherapy, it's important to look into how their insurer handles covering it.
According to Pomelis and Ramos from 2023, an article, they have described how technology has become more readily available even in remote areas, and there's more affordable options. This allows for more opportunity for those in remote locations to access services that they need. So many states have internet subsidy programs that offer internet at reduced cost, as well as companies such as Verizon that provide internet services offer things that can give internet to low-income families for almost free through federal funding programs. Although telehealth does require greater parental or caregiver involvement, frustrations and concerns can often be balanced with taking proactive measures and concerns before the telehealth is implemented. The article by Lerman discussed how there's a wide range of how caregiver involvement is based on service model, training, prompts, reinforcers, and schedules. But no matter what, clear and direct expectations that are discussed prior and during intervention sessions can improve this dynamic. Also, sending reminders a day before sessions and 30 minutes before a session can help to engage parents and caregivers and lessen the burden on them. Telehealth specific practitioner skills can also improve parent relationships. This includes using direct greeting to the parents, using everyday language, being respectful and understanding, and providing frequent positive reinforcers to caregivers, parents, using collaboration to understand what they are thinking and feeling on their end in order to give the most effective services, as well as providing directions for their own implementation as well. Overall, the studies that we have discussed and read have showed that telehealth ABA services have comparable effectiveness to those in-person services. So especially if precautions and proactive measures are taken, this can create a successful telehealth plan for those that need ABA services. It was discussed about how there can be a lesser sense of community within telehealth services, but to counteract or attack this, there is always an option of mixing telehealth with in-person services. Although this won't work for every client or situation, it can work to increase the cost effectiveness still, decrease practitioner strain still, and some of the other benefits of telehealth while also still using in-person services or in-person sessions to create that more personal relationship and connection. The downside to this is that it's definitely not possible for those that are using telehealth because they're in a remote or rural area where these services would not otherwise be accessible, but also for individuals that may have a hard time adjusting between telehealth and in person. That's not for everyone or every client, and that is just something that would have to be figured out between the therapist and the client. Another alternative to the idea of community or connections with telehealth is that telehealth can be used as a training method for parents, but also for therapists to expand their knowledge and expertise to practitioners, allowing practitioners to expand their repertoire and skill set, and then use what they learn via telehealth, deliver it in person to clients, via in-person, in-home, or in clinic-based sessions, for things that they weren't formally trained in. Although this is not direct telehealth services, this is still a way to incorporate some of the benefits of teletherapy into the ABA community.
While there is a previous point made that internet networks are more readily available and cost efficient, connection remains an ongoing issue, and internet cannot always be considered reliable. Many people could relate to this issue, especially those viewing this debate who may have had experience with teletherapy and/or classes held through a live video application during the height of COVID-19. Connection issues may be detrimental to clients attending a teletherapy session, as timeliness of prompts, reinforcement and or punishment schedules, behavioral interventions, and demands placed throughout session are crucial. While teletherapy may offer flexibility scheduling-wise, regardless of practitioners and caregivers agreeing on a time to meet, practitioners may not have their full attention. Parents may feel more comfortable in the setting of their choice for a teletherapy parent training session, though too much comfortability can lead to further issues. For example, parents may be interrupted to tend to their children or do other errands or household tasks. This lack of attention given toward the practitioner can lead to issues of miscommunication and potentially put a damper on rapport and buy-in. The sense of comfortability teletherapy could offer can also be detrimental, as cancellations might be more frequent. For some, it seems easier to cancel a teletherapy session as there is a lack of guilt regarding the inconveniences that come along with it. Since there often is not a travel aspect paired with teletherapy, a minor scheduling conflict may lead to a cancellation, as it would be convenient on their end, but perhaps still a hindrance on the other end. Holding a meeting or session in person adds more of a sense of responsibility to attend. It was mentioned that teletherapy can be beneficial as it may offer an increase in frequency of sessions held. While this may be true, other points previously made regarding the quality of teletherapy lacking in comparison to in-person sessions raises the idea of quality over quantity. To touch on another previous point made in favor of teletherapy regarding alleviating burnout, if session frequencies are increasing, then that point is somewhat contradicting. The pro side's final key points include mitigating social stressors, increasing generalization, and continuity of services. Code 3.12, advocating for appropriate services. Behavior analysts are responsible for advocating for appropriate methods of treatment to meet defined client goals. Code 2.19, addressing conditions interfering with service delivery. BCBAs are also responsible for identifying any environmental conditions which may interfere with service delivery and modify service delivery to meet the needs of the clients. For many children with autism spectrum disorder, frequent exposure to social stressors can inhibit the ability to meet skill acquisition goals, and many are even disrupted by the behavior of their peers. Telehealth may allow for learning in an environment free of these environmental factors. Code 2.09, involving clients and stakeholders. Behavior analysts are responsible for involving parents and stakeholders in treatments. Telehealth promotes parent training and allows for generalization of skills across people within the home environment. And lastly, we have Code 3.14, facilitating continuity of services. As behavior analysts, we must avoid interruptions or disruptions of services, and telehealth may allow for continuation of treatments regardless of health or travel circumstances.
It remains true that the use of teletherapy and the application of ABA therapy comes with practicality concerns, such as relying on a caregiver to provide prompting and behavior intervention strategies. It also relies on untrained individuals, which may result in delayed or stagnant progress for the client. This also defaults the responsibility of implementation onto the shoulders of the parent or caregiver, which can lead to heightened stress levels. This also might lead to the parent feeling unsupported. Parents already self-report high level of stress, and they also already self-report that virtual parent training sessions do not result in changed levels of stress. Practitioners must consider their ethical obligation to their clients and stakeholders when considering virtual ABA therapy sessions or parent training sessions. Oftentimes, insurers might not approve of teletherapy services. BCBAs must adhere to their terms of agreements, their quality of services, including implementation and data collection, as well as utilizing evidence-based practices, which again, ABA therapy has been studied in the context of in-person practice. Therefore, all research that exists on ABA practices were done so in person, thus leaving virtual ABA therapy vulnerable to being an unethical practice at this time. Lastly, technical barriers do exist. In-person therapy may allow for practitioners to utilize reinforcers and materials that are physically present, whereas in virtual therapy sessions, practitioners might be required to provide materials and reinforcement virtual, which can require technology that might be difficult for practitioners to manage. Other technical barriers that might be considered are the affordability of the technology on both the practitioner's end and the client's family.
So that concludes the remainder of our debate for telehealth and the ethical underlying questions behind it. We just go over what we talked about. We went over some of the benefits of telehealth, including cost effectiveness, managing staff shortages, as well as improved quality of therapy. There is also a lesser commute time for both families and practitioners. Sessions can be completed in comfortable environments so that clients are in their home space. And there is definitely an improvement of remote opportunity and services for those in rural locations that could otherwise not have access to ABA services. There are some limitations and barriers, of course, including caregiver implementation and training, a question of the quality of implementation, also if coverage is covered, insurance is covered for telehealth services for all individuals. There can also be internet access or technology barriers, and there is oftentimes difficulty implementing telehealth direct services for certain behaviors, including those with elopement and escape. But with proactive measures and additional research, that these limitations and barriers can be combated. Further studies of telehealth services will definitely help to improve and benefit telehealth and how it can be used with ABA. So we just want to conclude by thanking you for your time and attention, and we hope you found this debate to be informative and thought-provoking towards the future of telehealth in ABA. We have also included our references for you to view.